we present a video on early endoscopic realignment for urethral distraction injury, brought to you by the Department of Urology at the University of Washington. Urethral injury is suggested by blood at the urethral meatus in patients with pelvic, perineal, or genital trauma and is evaluated by obtaining a retrograde urethrogram. If a urethral distraction injury is identified and a urethral catheter cannot be safely placed, these patients are candidates for primary urethral realignment. If the patient is unstable, primary realignment can be delayed and a suprapubic tube can be placed in the acute setting. We favor placing a council tip catheter if realignment is anticipated, in order to facilitate percutaneous bladder access in the future. In this video, we present a case of a 39-year-old male who sustained a pelvic crush injury and subsequently underwent urethral realignment. A retrograde urethrogram was obtained due to suspicion of a urethral injury. This showed a urethral distraction injury at the membranous urethra. Benefits of primary urethral realignment include the possibility of avoiding a future open reconstructive procedure and better alignment of the urethral segments for downstream future reconstruction. Some orthopedic surgery teams also prefer that patients with pelvic hardware do not have a suprapubic tube due to the risk of infection, and this may also guide management towards primary realignment. Urethral realignment can be done in cases of partial or complete disruption if urethral access cannot be established. This is an elective procedure that should be done in a stable patient in coordination with the trauma and orthopedic surgery teams within the first week of injury. Necessary equipment includes 2 flexible cystoscopes, each with their own setup, 2 wires, a renal dilating set such as the Amplatz dilator set that is pictured, C-arm fluoroscopy in contrast, and a 16 French council tip catheter. The patient is positioned supine with the suprapubic tube prepped into the field. 1 video tower is positioned at the patient's head and 1 is positioned at the patient's foot. The C-arm is then positioned in an AP orientation over the pelvis with the ability to rainbow the C-arm to obtain oblique views. The procedure consists of 4 main components, which we will review. First, 50-50 contrast is used to fill the bladder through the suprapubic tube in order to delineate the bladder contour. If the patient does not have a suprapubic tube, percutaneous access to the bladder should be obtained at this point. We can see this patient's bladder being filled. A mix of 50-50 contrast is used so that it does not obscure the visualization of subsequent wires and dilating instruments. A suprastiff wire is then placed through the suprapubic tube and into the bladder, and fluoroscopy is used to confirm adequate placement of the wire in the bladder. The suprapubic tube can then be removed over the wire, leaving the wire in place. Using a stiffer wire here subsequently allows for easier dilation of the tract. Next, the suprapubic tract is dilated. Using the Amplatz renal dilators, the tract is dilated up to the size of the smallest sheath that will accommodate the flexible cystoscope. In our set, the smallest sheath is a 24 French, which will easily accommodate the scope. Dilation is performed under fluoroscopy to confirm correct positioning and avoid bladder injury. Once the sheath is in place, the dilators are removed and the wire is left in place. This fluoroscopic image shows the 24 French sheath in position within the bladder. Next, cystoscopy is performed both through the suprapubic tract and through the urethra. Both cystoscope operators have their own tower and advance their scopes into the urethra to the point of injury. Once the scopes are advanced, C-arm is used to align the scopes. First, the scopes are aligned in an AP view. Next, the C-arm is rainbowed to obtain oblique views and the scopes are aligned in this oblique view. It may be necessary to switch back and forth between the 2 views in order to get the scopes aligned in both directions. Once the scopes are aligned, the light is turned off of one cystoscope and the operator of the dark scope then seeks the light of the other scope. If the urethra is completely distracted, one of the scopes may need to be passed beyond the point of injury before the light is turned off to facilitate the scopes finding each other. Once the dark scope can be seen by the lighted scope, A guide wire is intubated through one scope and into the other to establish through and through access. We will now watch this process. We are looking at the view from the urethral scope, which maintains its light source throughout the procedure. The scope is advanced to the site of injury and then waits there while the other scope turns off its light and seeks the light of this scope. We see the suprapubic scope come into view. A wire is then passed through the urethral scope and into the suprapubic scope. Next, looking from the suprapubic view, the scopes have been aligned and the light of this scope has been turned off. The light from the other scope can be seen and followed until the urethral scope comes into view. The suprapubic scope is then held in place as the wire is passed through the urethral scope and into the suprapubic scope, bringing them in close proximity as through and through access is established. The scopes can then be removed, leaving the wire in place. A 16 French council tip catheter is then placed over the wire from the urethra. At this point, the suprapubic tube can then be removed if wanted. This fluoroscopic image now shows the catheter passing across the urethral defect and into the bladder. The catheter should be left in place for 3 to 6 weeks, depending on the extent of the urethral injury. A pericatheter rug or VCUG should be obtained at the time of removal to ensure there is no continued urine extravasation. The majority of patients who fail after catheter removal occur in the first 6 months, with a mean failure time of 2 to 3 months after catheter removal. We follow these patients in our clinics with uroflows and post-void residuals. We may perform cystoscopy if indicated by their flow rate or PVR, or if they develop obstructive voiding symptoms. Overall, realignment is performed fairly easily and quickly. At our institution, it typically takes less than 20 minutes to perform realignment. If realignment is difficult or the duration of the realignment attempt is prolonged, the suprapubic tube can be replaced and realignment can be abandoned. Based on our own series of patients that have undergone realignment, the failure rate is high, warranting close follow-up of these patients after catheter removal. Realignment is a tool for reestablishing urethral access that can be done quickly and on an elective basis. We try to limit excessive irrigation during the procedure to avoid significant periurethral extravasation. We also advocate early referral to a reconstructive urologist if realignment is performed in order to determine the patient's subsequent management plan.